good afternoon for some of you, good morning for some of you. Thank you so much for taking the time from your busy schedules and to join us for our first COVID-19 webinar. We're glad to have this mixed audience, it looks like, of some patient partners and citizen partners and researchers. So we hope that you'll find this discussion interesting. We're going to do a very brief introduction, and then we're going to get right into the fireside chat, which I'm positive that's why most of you are here. So I'm going to start, and Andrea Tricot and FP Gauvin will introduce themselves when it comes time for them to speak. So I'm Maureen Smith. I'm one of the two co-leads for the Citizen Partnership Strategy for COVID-19, and I'm also the chair of the Cochrane Consumer Executive. Okay, next slide, please. So we basically have two objectives. One of them is to give you a little bit of an overview of COVID-19 in Canada and how patients and citizens are engaged in this, and to have this interactive fireside chat with this wonderful team that you'll get to meet in a very few minutes, who have conducted a rapid review as part of a vaccine guideline for immunocompromised Canadians. And they're going to talk about their experience doing that and how they carried out their patient engagement. And I just want to add also that we're bilingual here. So if you want to ask your questions in French, or there's no problem. There's no problem with that at all. We're happy to take questions in English or French. Okay, next slide.
Perhaps I could jump in, Maureen.
Yeah, I already took your first slide, so sorry about that. I'm supposed to be looking where it says FP. That's you. So that's go ahead. Sorry.
Hi everyone. So François-Pierre Gauvin. I'm with the McMaster Health Forum, and I co-lead the Citizen Partnership Strategy of COVID-19. So it's a pleasure to be here with you. So just to give you a little bit of overview of what's COVID-19 in Canada, and we also have some of the main investigators with us today who can provide additional feedback and details. But COVID-19 is a time-limited network that brings together more than 50 of the world's leading evidence synthesis, technology assessment, and guideline development groups around the world. So it's a global network. But we recently established a Canadian component to COVID-19. Since January 2021, the Government of Canada, through the Canadian Institutes of Health Research, have invested $1 million in COVID-19 to support Canadian needs more specifically. And in the work of COVID-19 Global, but especially COVID-19 in Canada, there is a very strong commitment to citizen partnerships. So we want to make sure that we involve citizens, patients, families, communities in the work that is being done, and especially in producing evidence syntheses. A bit of context again in terms of the pandemic. So you know that since the beginning of the pandemic, decision makers at all levels of government, but also in many different sectors of government, I've been juggling and struggling with various types of decisions. And often to make these types of decisions, they're looking for evidence and information and data to make informed decisions. It could be decisions about the public health measures. So and still today, we have discussion about masks. What are the most effective masks in the community, in care settings? Information needed about tests, curfews, quarantine, and other types of public health measures. There's also been a lot of discussion and need for evidence about the clinical management of COVID-19. So is there any prescription drugs that could be effective? But also clinical management of other conditions that are related to the pandemic. So something that comes up very often in the news is the need to support people who may have mental health and addiction issues during the pandemic. Decision makers may also be interested to learn more about health system arrangements and how can we strengthen and adapt health systems to face the pandemic. So how can we scale the capacity of hospitals? How can we implement virtual care to provide care to those in need, as opposed to provide services and programs in person? And lastly, but nonetheless, a lot of questions and decisions that need to be made about the economic and social responses to the pandemic. Could be about what to do with school closures. How can we adapt public transit system? How can we better support perhaps people who may have housing needs, and so on. So a lot of questions that decision makers have. And to do that, we're hoping to provide them with evidence, but it's a bit challenging to do that in the context of the current pandemic. We know that knowledge about COVID-19 and its impact is evolving very, very rapidly. So sometimes research that is being conducted a week ago may not be relevant today. So it's changing very rapidly. We know also that there's been a lot of efforts to synthesize research evidence that is available, but these efforts may not be well coordinated. So in Canada, we may have multiple groups doing the exact same research synthesis to see the effectiveness of different types of masks. So we're working in silos as opposed to trying to put our energies and efforts together to work in a coordinated way. Also, we see that the quality of the evidence syntheses that are produced is a bit variable. So again, we want to make sure that we can provide decision makers with the synthesis of the highest standards, those that are very robust and high quality. And lastly, we have new evidence users from across different sectors. So not just the health sector, but education, community and social services, transportation, food safety, and so on. And these new evidence users may not be aware of the best available resources and tools that are currently available. So with that in mind, this is some of the challenge that the COVID-19 initiative is trying to address. And I'll move to the next slide with Maureen, who will give us a bit of an overview of what we mean by citizen partnership.
Yes,
Maureen?
Thank you, FP. And I'd also like to note that the polls are now open in the chat box. You have to scroll all the way up. So if you haven't filled out the poll, it would be great if you did that. It looks like there's 2 versions of each poll. I think John said to do the first one. What did you notice, John? Do the
yeah. Sorry, Sarah was pointing out that it's one. It's just that there were so many provinces and territories. It looks like it appears across 2.
Okay. All right. So if you want to go ahead and fill out the poll, that would be great. We can see who's online. So I just wanted to make sure that we're clear on COVID-19's definition of citizen partnership. So with COVID-19, we're talking about citizens, and that includes, of course, all of us people who are living in Canada, regardless of their formal citizenship status. Secondly, communities. Thirdly, all patients and potential patients. And lastly, families and caregivers. So, we often talk about patient engagement in research. For COVID-19, it really is citizen and patient. So we use that one term, and that's for all of these people. Next slide, please. So why engage them? Well, it's pretty obvious that many of the COVID-19 research topics are relevant to citizens. So as François-Pierre mentioned, the public health measures, all the societal economic impacts, thus engaging them is essential. And here's the one that I'm especially proud of. At COVID-19, we consider citizens to be decision makers too. So they are making personal decisions that have tremendous societal impacts. There's a lot of focus on decision makers, and we are included in that group. And the last 2 are, for any kind of research, we can help shape research to be more responsive to the needs of Canadians, and we have this unique knowledge that can help to interpret and contextualize research evidence. Next slide, please. So I just wanted to show that there is a range of involvement going all the way from inform to empower. I think you'll enjoy the fireside chat because you'll quickly see where they were on that scale. There's no right or wrong way. It depends on the topic. It depends on what you're able to do. But these are examples of how you could be engaging citizens. So, in your plain language summaries, in making decision on the outcomes, et cetera. But there really is that range, and you're going to see in different rapid reviews, you're going to see examples of how you can work with that range. Next slide. And again, here it's showing you where in the process the citizens can play key roles. So if you may be able to identify the research gaps, you definitely can say what are the patient relevant outcomes. You can provide feedback along the way. You can contextualize data analysis, and at the end you can disseminate it by co-producing the plain language summaries and the infographics. Next slide. And so finally, this is our last slide before we go right into the fireside chat. There are opportunities to be engaged with COVID-19 in Canada. So we're encouraging nominations from a diverse range of citizens. We're looking for a pool of approximately 20 people who can bring different perspectives to our rapid synthesis work. So again, identifying research questions, identifying outcomes important to you, feedback on synthesis, contributing to plain language summaries. In the chat box, you're going to see the link for you to submit your candidacy. And we're going to be looking at that over the next few weeks and really trying to create this pool of people who we can call upon who are ready and willing to work with researchers to jump in when needed. Okay, and I think that's it for me. Next slide. And I'm going to hand it over to Andrea Tricot, who's going to introduce herself and introduce the fireside chat.
Great. Well, thank you so much, Maureen and Francois Pierre. Real pleasure for me to be here today with everyone. My name is Andrea Tricot, and I'm a scientist with Unity Health Toronto, and also leader of the Sport Evidence Alliance, where we've been working with our patient partners on multiple avenues, including engaging with them as equal partners in our rapid reviews. Also a pleasure to be a part of the leadership for COVID-19 in Canada. So we're going to have a fireside chat, which I think is going to be incredibly informative for everyone here. And I'm super excited to hear the great experience as well as learn from everyone here today. So perhaps what we'll do is we'll have our panel members. Oh, great. Okay, Maureen. Yeah, so this is great. So I'm going to explain how it goes, and then we will get everyone to introduce themselves from the team and then provide the context as well as their opening statement. So after we hear an introduction from the team and their contacts, an interactive chat will begin after this. So you can use the chat function to post your questions. And so either if you put it into the chat, then myself, Maureen, and Francois Pierre, we will read your question. Or if you want, we can unmute you and you can say your question by raising your hand. So it's up to you, your preference, if you want us to read it or if you want to state your question. And again, we welcome your questions in English and French. So again, complete pleasure for me to be here today. Super excited to be here with everyone and learn from this fireside chat. And I'm going to open it up to our panel members to get this started.
Thank you, Andrea. Glen, go ahead.
Yeah, thank you. I think actually the next slide we have all the introductions. So I'll wait. Oh yeah, we can start with that now. So I'm Glen Hazelwood. I'm an associate professor in Calgary and a rheumatologist. And relevant to this, I chair the guidelines committee through the Canadian Rheumatology Association. Laurie?
Yeah, sorry, it just takes a bit of time on Teams. Hi, my name is Laurie Proulx. I'm a patient partner. I'm also, so I've been involved in a lot of Glen's projects over the years, but I'm also on the executive of a patient organization called the Canadian Arthritis Patient Alliance. And I've lived with juvenile idiopathic arthritis for close to 30 years now. So I'm happy to be here today. And I'll pass it on to Dawn, who hopefully can unmute herself. Yes.
Looks like I can.
Good.
Thanks, Laurie. So hi, everyone. My name is Dawn Richards. It's a pleasure to be here. Like Laurie, I'm a patient partner on the team. So I've lived with rheumatoid arthritis for nearly 2 decades now. And like Laurie, I'm a volunteer vice president for CAPA, or the Canadian Arthritis Alliance. Just briefly, CAPA has no employees, no bricks and mortar. We are primarily funded by independent grants from the pharmaceutical industry, but we also have other forms of financial support as well. And just really happy to be here. Thanks for having me.
Hi, everyone. I'm Robby Nieuwlaat. I'm an associate professor at McMaster University. I'm a clinical epidemiologist, and I was the methodology co-chair on this guideline with Glen. Nice to meet you all.
And hello, I'm Jordi Pardo, and I'm one of the managing editors of Cochrane Musculoskeletal, and I'm helping the Canadian Rheumatology Association providing methodological guidance for their guidelines.
Perfect. Glen, would you like me to go back to the first slide?
Yeah, if you could, JP, thank you.
Thank you. Here we go.
Yeah, so the context for this, so we've, the Canadian Rheumatology Association has a guidelines committee, and we've done a few guidelines, and typically with our guidelines, we have a lot of sort of advance warning with the guideline. This one came up sort of over a weekend. I got a text from somebody who had seen the recommendation that the National Advisory Committee on Immunization had put out regarding the COVID vaccine in patients with autoimmune disease. And that's kind of where this all grew from. And I know at the same time, Dawn and Laurie were also getting texts from people and lots of concern. And the concern was that it was a strong recommendation against the vaccine in people with autoimmune disease or people who are on immunosuppressive medications. And so that's really where this whole guideline rapid review started from, was just this concern. Along the way, they've since modified the recommendation to indicate that the vaccine may be offered if the benefits outweigh the risks. That sort of happened within the process when we started this. But really this came from both patient and rheumatology communities as an urgent priority, and that's kind of how we all got together. And so this is the kind of jump through the whole process to the end, just to give some more context of what we ended up with. So this was a recommendation. This all came together really from the time where we started the process to publishing the guideline. I think it was about 4 weeks. So it was a lot of work in terms of the evidence review, a lot of commitment in terms of the panel. We thought it would be done in 1 2-hour panel meeting. It ended up taking 3 2-hour panel meetings. So, but it was a really sort of rapid process to come to this statement. And so this was the recommendation we published last week, which was that we should be, so the CRA guideline panel suggests the COVID vaccine in people with autoimmune disease. And really what it came down to is strong evidence of benefits in the general population. And extrapolating from other vaccines, we thought that there'd still be strong benefits for the majority of patients, but that there might be some people who are at particularly low risk of COVID infection who might want to wait until more information is available. So that was really kind of the culmination of the four weeks of our evidence review and process. And we can move to the next slide, JP. And so these are some, I think at this point we could kind of open up the fireside chat, but there's many examples kind of along the way of how important patient involvement was, and we can talk about those.
No, thank you so much, Glen. Nice, so lovely seeing you, and thank you for introducing this really important work that you've all been working on. So I at the moment, I don't see any questions. So, and I don't know if I don't see anyone's hand up. So now we're opening it up for questions, and maybe to get people warmed up, is it okay if I ask a quick question?
Andrea, can I just interrupt for a second? Okay, we had said that the other 4 panelists could each make a brief statement before we go to the questions, so we can get to know them and what their roles were. That will guide us in the questions too. So sorry to jump in there. So
no, okay. I love that idea. Okay, continue on. Thank you.
So maybe we can start with Laurie.
All right. Yeah, there we go. Yeah, so so I guess one of the things that I see as being pretty important, I guess, and that really helps set the stage, I think, for the work that we did is just the long-term relationship, I guess, that both Dawn and myself have had with Glen Hazelwood. So I think, you know, we're part of the Canadian Rheumatology Association Guidelines Committee. And so really, we've been working collaboratively. I think I met Glen in Lake Louise, Alberta, if I recall, at the Canadian Rheumatology Association meeting 5 years ago. I think it was been 5 years. And so I think that just shows how, you know, by establishing some of those relationships with patient partners, I think it allowed for this collaboration to happen more quickly, more, you know, and with greater ease, because I think we had a working relationship, we had worked well as a team. And so, yeah, I just thought I'd mention that as far as like setting the stage and maybe, you know, provoking some questions or starting some questions on that. So we've been pretty fortunate to have that relationship and having, you know, work together on a number of different projects related to the RA clinical practice guidelines. So then when something urgent like this comes along, it's almost like we're already set up as a team and we're sort of ready to go. So that's just one maybe context piece I thought I might add to, you know, start some conversation, but I might pass it on to Dawn. I don't know if you have anything else to add.
Yeah, I think, thanks, Laurie. I think that was a really important one, that we already do have this relationship with Glen. So with the guidelines and also working on some other CIHR funded projects together. So we already know Glen is a real champion of having us at the table. And back to one of Glen's points too, you know, back in December when the National Advisory Committee on Immunization published their statement about initially not recommending vaccination for populations, we were also really confused because we're seeing everywhere else in the world actually do the opposite. So for our specific populations, they are strongly recommending vaccination, and we are also priority populations in those other countries. And so it was kind of a little bit serendipitous. I mean, it's a really important topic, but both of our communities were pretty, I'll say, like agitated or excited about things. So it's just nice that we can mobilize as a team fairly quickly. I think also important to know is that even though Laurie and I have been on the guidelines group, and I know Laurie's got a bit more background with the grade process than I do, importantly, Glen and the CRA also offered us the opportunity to take the kind of beginner grade course from McMaster. So it was just a really frenzied time where we sort of dropped everything. Laurie and I also work. So we, like the other panel members, are doing this off the side of our desks at night and whenever else we can. So I'll just add in that context about some of the supports that were provided to us as well.
Robby and Jordi, anything you'd like to add?
I can go next. So there's Robby. So my role on the panel was really as a methodologist. So I'm involved in guideline development. And I got involved with this group to make sure that we follow the methodology that is recommended to get to good evidence-based recommendations to guide our practice on. And what we typically tend to do is we want to have, as we call it, multiple stakeholders involved in developing good practice recommendations and guidelines, which means that not only clinical experts, but also people like me who are methodologists, but definitely also patient representatives or citizens in general to come to agreement on what is a good recommendation from all these different perspectives with input from different angles. It was a really nice process. As Glen said, it was very fast, but it was a great group. I think the patient representatives, so Laurie and Dawn, did a great job. As they already indicated, they're already pretty experienced with doing some work like this. So I think that made it a bit easier for them. But I would say their input was really important at different steps, but especially to put things into context, to pull us back if we were talking about things where there may not be a lot of scientific evidence, and they were able to explain to us how patients are typically thinking about certain decisions. And I think looking forward, and so we do this for other guidelines as well, we try to actually get patient representatives or citizens on the panel, so they're actually equal panel members, they have equal votes in what eventually will end up as a recommendation. And looking forward, so once you have a recommendation or guidelines, you want to implement it and disseminate it. And so patient representatives as citizens can then also play a really important role in determining how should this message go out, how should it, which person should it end up, in what form. So I think it's really important. And so in this case, it was a very nice process. We're looking to keep these recommendations, as we call them, living. So as new evidence comes out, we want to reassess to see if we need to look at this recommendation again, if we need to change anything in our wording. And again, also in this process, they will be very important. So that's my perspective on the experience with this panel.
Okay, it's Jordi here. Well, my job in this guideline was mostly to put together the evidence that will help to inform the process. So on that sense, the timings were really tight. So it was the challenge itself was just to get something we can show the panel hours before we get into the meeting. But what was extremely interesting from my side on being on the panel is that it was a lot of people with really strong opinions and thinking about where the recommendation should go. And even with a situation where sometimes was really challenging of trying to put together sometimes opposing views, it was quite shocking to see, or probably not the best expression. It was pleasantly surprised about how willing the people were to find consensus. And I think it also goes to the importance of having built a relationship with the patients beforehand, because some of the discussions were hot. And I think what helped us to go all the way through is the confidence that was built over time, that helped that people were spending time listening to each other's positions and trying to find a way that could be a compromise of all the views that were expressed in the panel.
Great. Thank you so much, everyone, for providing the extra context and for your individual contributions. I still, at this moment, don't see any questions. So Maureen, is it okay if I ask a question?
Absolutely.
Yeah, okay. Thank you. So I would love to hear from the patient partners, Laurie and Dawn. So Laurie and Dawn, it sounds like you have a lot of experience engaging in research. And so I was just very curious to hear from both of you. What has been the biggest challenge that you have faced as patient partners working with researchers on these types of initiatives?
Laurie, is it helpful for me to start?
Yeah, sure, if you don't mind. Yeah.
Okay, no problem. So I guess I should maybe also add some context for people. I'm trained as a researcher, although I'm not an academic, but I actually do a lot of work in patient and public engagement as well. And so I'll be brutally honest with you, Andrea, that in my own work, I often will take things that I've learned from my own experiences and want to do a better job of. So just generally things that as a patient partner I've seen like over the years. I'm not saying it's with this team necessarily, but for me there's simple things like the time of day that your meeting is, right? Like how flexible are you for people? You know, many patients work, right? And so is during the day useful or not? But that's been fairly flexible for me for the most part. Things like compensation, I'll be honest with you, is a really hot topic. It's also a topic I've written a lot about because I feel very passionate about it. But I'm seeing the pendulum swing on that one too. And just other considerations, I think, that help bring voices to the table that may not normally get to be there. So I think those kinds of things are some of the things that I struggle with. I'll say too, and I'll credit Glen, that he's created a really supportive environment for Laurie and I. So to Jordi's point about some of the topics with this latest rapid recommendation being really hot topics, you know, he's created a sense of trust with Laurie and I that we can have very brutally honest conversations with him, either within those meetings or separate from meetings, so that we can really get our points across. So again, that's a real credit to Glen and his approach with working with us. So hopefully that starts things off for you, Laurie.
Yeah. No, and I would agree with all those things, you know, that those are all, you know, really excellent points. The one other thing too, and I'd say, you know, can be challenging at times, but I mean, I've been through a lot, you know, in my 30 years of living with the disease, you know, through adolescence into young adulthood and parenting and that. And sometimes I guess it's reconciling. There can be a lot of difficulties, right? Reconciling lived experiences that aren't based on a, you know, methodologically sound, you know, like I understand the research process now, but lived experiences are definitely very unique, right? And although if you do marry those two things together, because I mean, not everything is ever going to be researched, right? I think it was reflected really well. Dawn did a presentation last week and a couple of tweets from patient partners were noted. It's sort of like somebody in particular, Isabel Jordan, who's quite active as a patient partner in the rare disease community. I think she says, no one's got the corner on the truth, right? And so the point of research really is to kind of understand those truths, right? And but patients have you know, an element of that, and I think it can cause friction, right? Where you've got the typical research process, which I have a great amount of respect for. I mean, I wouldn't be doing everything I do today if I didn't, you know, but reconciling that with lived experiences, I think, can be difficult, right? Sometimes there are truths that I know that maybe others don't. And that's why I'm there, is to try to bring some of those untold truths to the table. Because you will never have the full truth, honestly. Like, you'll never be able to research all those things, like, at least in my opinion, right? You'll never be able to. And so this is really where the value of patient partnership comes in, right? Is to sort of bridge some of those gaps and create something better bringing those two methods of knowing, right? We talk about knowing, different ways of knowing when it comes to, reflecting on contributions of Indigenous people and what that sort of thing. But I think it's sort of similar. It's sort of building on that concept that there are things I know that maybe researchers will never know unless they bring us to the table and sort of bring that together. And I think this guideline is a great example of that. Personally, it was very emotionally charged and hard on me at times, but I think at the end of the day, I feel like I actually made like an important contribution to the pandemic in a way, right? I'm doing something, bigger than myself, and helping other patients as well. So.
Great. No, thank you so much to both of you for sharing that. And just to highlight some of the common themes that I heard from you were things such as, and I'm going to frame it more as enablers versus barriers, but having, those long-term relationships and being able to create a brave space where we can really have those heart-to-heart, honest discussions, and also working together with researchers who recognize the importance of lived experience and how that can really be helpful in the interpretation of research. And as well, something that's really important is making sure that patient partners are recognized and acknowledged and compensated adequately. So that's fantastic. Thank you so much. I think I'm going to pass it to Francois Pierre to moderate the next discussion.
Thanks, Andrea. And I see a few hands raised and also a comment in the chat box. Perhaps I could turn to Alessandra Jaramarillo Garcia. Alejandra, are you able to unmute yourself and ask your question?
Yes. Hi, everybody. Thank you for the invitation to participate in this very important discussion. I am a methodologist researcher working with the Public Health Agency of Canada. We're working on rapid reviews, topics related to the unintended consequences of COVID. And I'm very keen. I mean, I've read the evidence on how important, and I can see it and hear you all speak about the value and the benefit added, a very important benefit of having patients engaged. We're still in the initial stages. We're getting, kind of everything lined up to do this. And I guess, I wanted to see if there were any tips that you could share with me on how to engage patients or people with lived experience on topics where stigma is a big concern. So, for example, on topic like family violence or self-harm and suicide, I'm getting quite a bit of pushback even from researchers on whether, this truly makes sense on topics like this or not. And, like I said, this is somewhat new for us and the agency. But yeah, these are definitely, these are two topics that we need to work on in the next few months. And so I would appreciate getting input on that. And I had one more question, which is just, it seems like you all have a relationship already going. And I mean, I've heard Andrea and Maureen and others talk about the importance of the relationship. And I understand that clearly. For us, that relationship doesn't exist yet. And we need to produce this very quickly. The scope of work for my team is really broad. Topics are very important. It's that kind of second part that comes after the infection, right? It's all these unintended consequences. And so, I'm still trying to figure out in my head, how do we actually go about getting started with topics that are so, to a certain point, controversial, even, about whether involving people with lived experience, and then engage them in a way that is respectful and still being able to get that value that we need for these topics. So those are the two questions. Thank you.
Thank you, Alessandra. Anybody from the panel would like to respond to Alejandra? Even Maureen and Andrea, perhaps, based on your experience? Who would like to go first?
I mean, it's Dawn. I'm happy to add a bit if it's helpful. Thanks for your question, Alejandra. I think that this is really important, and I think especially for very vulnerable populations with these types of topics, if there are ways that you can find that will support them appropriately to be able to work with you. And I'll just warn you that it might be a lot more intensive for those specific types of populations than some others. But I would encourage you to at least look into how you might do that. And again, you might engage those types of individuals in ways in which you wouldn't normally engage everyone by throwing them into a room and having the same kind of discussion. So I guess I would just ask you to think carefully about what the engagement potentially looks like, but I wouldn't ask you to shy away from it, because I think it's really important. And I think, one thing that Laurie and I found out, well, we're not representative of vulnerable communities in the sense that you're talking about. We brought a lot of context to the grade review that many of our clinician colleagues were unaware of. And so, there's like a lot of kind of on the ground everyday things that we live with that people who don't live with our conditions simply can't understand, like Laurie said. So I just think that it might be more difficult to engage these types of individuals, but I'd strongly advise you to look into how you might do that with providing them the appropriate types of supports.
Thank you, Dawn.
It's Jordi here. I can share some thoughts from my experience, and I will say I will agree with Dawn that it's worth the try, and I think that it's an area where failure, I think it should be accepted that it may happen. It may be hard to engage with these people. We did a program of research with Cochrane and different institutes of Indigenous health in Canada, Australia, and New Zealand. And one of the topics that we did here in Canada was about suicide. That it's one of these topics that it's hard to work on. But I think one of the interesting things of making a liaison with the Institute of Indigenous Health is that they were able to be the proxy to identify people that could be the final users of that. And so even if you don't have the time to build this trust relationship, if you came recommended by someone who does hold the trust of the people you're going to try to be serving with the recommendation, I think that may work for you. And I will say it's really complicated because these are really sensible topics that it may be hard to open to a stranger to explain what is your experience and how it happened. But on the other hand, I think that these are people who really will appreciate what are the benefits that could happen from running this process. So I would say don't be afraid to ask, and don't be discouraged if you get a no by an answer. And then keep trying and keep suggesting and explore ways how that could work. So there are different ways how you can get people engaged, and it may be a different rhythms and at different levels of involvement, and be willing to accept what they can offer.
Mm-hmm. Yeah, and one thing I might add, just in terms of just even our experiences, like, I mean, Dawn and I know each other quite well, and I think throughout the even this recommendation, like developing it and during the discussions, like, I mean, we supported each other. And I do think that sometimes we don't recognize the value of sort of, it's a bit of mentoring support. Like, I don't know what the heck you call it, but there's something like that, like that you might want to consider, right? Is how to kind of build a community within the people that you might be looking to engage, and they can relate to each other. For example, like a lot of people I meet with inflammatory arthritis, I joke that we become like instant friends in a way, because it's just like, who knows better than the people who have walked in your shoes, right? So I think maybe don't underestimate the value that the others in that group might be able to support each other or work together or just create a safe space. Even if you're not included in that, that's okay, right? You can just let that go. And if they're comfortable, that's what you're there to do, right?
Thank you, Laurie.
And just to notice, Alejandra, someone shared a resource in the chat box. Mireille shared a resource from CFHI that may be of interest to you in that regard. And something that regarding the need for prior relationship as a potential enabler of patient-citizen engagement, I think that's quite a fundamental issue, and I believe this is something we're trying to address by creating with COVID-19, creating a pool of citizens, and that's our challenge right now, is to raise awareness about the need to have citizen engagement and citizen partnership in producing evidence syntheses, to get them interested in joining COVID-19, and also sustain their interest, so that whenever there's a request for a rapid review or rapid evidence profile, we could have this pool of citizens interested, ready to jump in on any request. And this is also something I believe, Andrea, that you have with the Spore Evidence Alliance, a pool of interested patients who may jump in on the rapid evidence synthesis.
I just, JP, sorry, wanted to add one thing. I think providing flexibility in terms of how patients engage is really important too. Some patients may feel comfortable, like like Dawn and Laurie joining a guideline panel, but others might be really intimidated by that. Similar to just commenting on documents, some patients may not feel like they have the they might feel intimidated doing that. So just having different ways, it might be an individual call with people to make sure that their voices are heard, I think is helpful.
Thank you, Glen. And perhaps Glen, if you want to have a look at the chat box, Helen Castle provided a comment and question specifically about the recommendation about the vaccine.
Yeah, I can address that. So yeah, actually the initial recommendation was actually should not be offered, and then they actually made a change, so it should not be routinely offered, and then the follow-up was may be offered. And there was we're not sure what the shift was from. I know there was a lot of public and sort of community pressure to change it, so I think that factored into it. But we weren't sure exactly. As far as we know, there was no sort of new evidence that was reviewed. The main difference in the approach that we took is the recommendation against the vaccine really was because patients with autoimmune diseases were excluded from the trials, we shouldn't use the vaccine. And we approached it from a different perspective, saying that, well, we actually have really good data on the vaccine in healthy populations, or in the populations that were in the trials. And then the real question is, is there a reason to suspect we'd see different responses or different side effects in patients with autoimmune disease? And there we really looked beyond just the COVID vaccine data. We really looked at the efficacy and safety of all other vaccine data. And then the other key thing, and this speaks to patient involvement, is how much are patients willing to accept a little bit of uncertainty in potential flares of their disease, which is kind of the theoretical harm, for the benefits of the vaccine. And there it was actually the patient input there really changed how we approach the evidence review. Instead of just looking at flares in general, which can be quite common in people with autoimmune diseases, we really honed in on the severe flares, and that really came directly from Dawn and Laurie's comments about, it's not these minor flares that we live with all the time, it's these severe flares that we're worried about. So that was really the key difference between our approach.
Thank you, Glen. Maureen, perhaps Maureen, certainly have questions to ask to the panel. And to
I guess I'm going to get the final question. I don't see any other questions in the chat box right now. So barring, I'm going to ask my own question. So I guess my question is really, what you've provided us is you had a very good, first of all, you had a rapid review and a guideline that was relevant to a lot of people. And then you had the patient partners who were totally committed to it. So what would you do if you didn't have those relationships? So you're a researcher, you've been charged with this rapid review. You don't have people that you've got relationships to work with, and you've got to do it rapidly. So maybe 7 to 10 days. So I'd like to hear from everybody, I guess, as your closing statements. What would your advice be in that situation so that we can hear from the people who want to be involved?
I can start with that. I think, I mean, the nice thing about COVID and a way for evidence reviews is I think a lot of people are really invested in it and really have been thinking a lot about it. So there may be, even speaking to these marginalized groups, trying to, get them involved. I think you might be surprised at how many sort of these groups might have this really high on their list of priorities right now. And so just reaching out, even, if you don't have those relationships, reaching out, and people may have been thinking about all these issues a lot, and just starting that relationship, and they may be willing to sort of, as Dawn and Laurie said, put things aside for a few weeks to add something that they see as important.
Maureen, I agree with Glen here. I think in that case, just being really open and honest with people, like, what's your timeline? What kind of supports can you offer? And by supports, I mean in terms of helping get people up to speed before maybe your initial meetings, or what kind of time they might need to invest in it. Can they be compensated monetarily, non-monetarily? So I think just being really transparent with people. And I think to Glen's point, I think is a really good one, that I think COVID has done really interesting things for science. Like, it's put it at the forefront of things. And there's all kinds of conversations around it. But I'd argue that, I do a lot of work in clinical trials, and clinical trials are at the forefront again, and it's not all of the terrible things we usually see in the news. So people do want to be able to contribute, and there's this certain feeling of like being at home and not being able to contribute right now. So I think just being really transparent with people about potential expectations and reaching out to groups that might have people who would be interested in doing this are a couple of approaches I would take.
Yeah, no, I would agree with what Dawn is saying here. Just trying to be really clear, trying to be as organized as you can, trying to try to build some of those one-on-one relationships with people, so that they know who you are, they know what the project is about. Like, don't hesitate to kind of make it personal and coach them one-on-one. Connect the patient partners together or citizen partners or whoever it is involved. Like, I think it's possible. I think you got to spend a lot of time up front, right? Just planning well, organizing things well, making them clear, making them feel like it's safe. Like, going back to some of our other points, that it's like, we want to hear from you, even though this is, you're not a researcher in the traditional sense of things. But I would think it's possible. It just needs to be a little different, right? Not having sort of these long-standing relationships that we've had and that we have to the rheumatology community at large. So.
Yeah, nothing really too much to add to what has been said. I will encourage people to say the longest journey starts with the first step. So just try it. Just you don't have time. You have 7 days. As Dawn says, be transparent. Be clear what you can do, what you cannot do. What are the timings? What you expect from people. And you may have some great surprises. You may get some people to say, "Well, I cannot do it now, but maybe the next time." And that's the start of a relationship that can be built for the future. So take the opportunities when they come, and if it doesn't come, that's okay.
Perfect. Thank you, Jordi. And thank you to our panel, Maureen. I believe we're just 3 minutes away from ending the webinar. So perhaps just a few concluding comments. Again, we're just launching our recruitment, so please, if you're an interested citizen, patient, family member, caregiver, whatever your background, expertise, whether you work in the field of health, education, housing, and so on, we're interested to get your perspective. So please submit your candidacy by clicking the link, which is provided in the chat box. We have a few questions there, a bit more details about COVID-19. It should take no more than 10-15 minutes to read everything, to complete the survey, but it's really appreciated. We are also providing a few guides to plan your engagement activities. So again, if you're a researcher or even a patient partner, citizen partners, these may be interesting resources and background information that could help you in your engagement activities. And also more specifically, if you're interested in resources to engage citizens in evidence syntheses, we have multiple resources that have been shared by Cochrane's COVID-19 Consumer Rapid Response Task Group. So you do have very brief documents for researchers, citizens on how to engage. You also have very interesting brief videos on YouTube that could be of interest. And also a few resources provided from the Evidence Synthesis Ireland group for patients, caregivers, and citizens. So again, I want to thank the audience. Thank you for joining us, the entire COVID-19 team, our panelists, Glen, Laurie, Don, Robby, Jordi, and of course, Maureen and Andrea for moderating the session and the fireside chat. So thank you so much. Have a wonderful day.
Thanks, everyone.
Thank you.
Thank you. Take good care.